Right, everyone, welcome back to our final day of the Surveillance and Response annual meeting. Before we start, I think I'll just have Professor Richard say a few words about yesterday and maybe recap what happened, our votings, as well as introduce our plan for today. So whenever you're ready, you can take over.
Karina, and hello and welcome to our third and final day of our annual meeting for the Surveillance Response Working Group. Yesterday, we heard about cross-border malaria. We had 3 examples of international borders where this is a critical issue and a potential threat to achieving or maintaining elimination status. We heard quite a lot about data sharing at local and national levels and the importance of having actions informed by that data across borders. We then went through our Surveillance and Response Working Group work plan for the coming year, for which you've given suggestions and voted on your preferred activities. So we'll give a little summary at the end of what our plans are going to be. To respect the agenda, we are going to go straight on to the first session. Session 3 for the meeting is panel discussion on sustaining malaria services and health access in diverse settings. So we'll have some presentations and then we'll have some time for panel discussion. After that, we'll hear more about the malaria community health worker performance assessment guidance that we already mentioned in the meeting, a chance to join the team to contribute to writing that guidance. And we'll finish with a session on geo-enabling malaria interventions, which will have a couple of country examples and then a presentation about opportunities for support for countries to do that. So on to our first session. The chair is Prudence O'Malley from Malaria Consortium, and I'll hand over to Prudence.
Thanks, Richard. So Richard explained the first session is going to be focusing on sustaining malaria services and health access in diverse settings. And this session aims to explore the challenges and expectations for the future of malaria intervention delivery in diverse settings, with a particular focus on community health workers. So we're going to have 4 10-minute presentations, so I'm hoping everyone will stick to their 10 minutes, and then a 20-minute panel discussion following. So could you please put comments and thoughts into the chat, but questions into the Q&A so that we can put them to the panel if we have time in the 20 minutes. So we've got 4 presenters today. The 2 of them are presenting multi-stakeholder perspectives. One is Dr. Win Han Oo, who is a medical doctor. He is the Regional Program Manager for Health Security and Pandemic Preparedness at the Burnett Institute. He looks at preparedness programs in Southeast Asia at the Burnett Institute. He's been managing a variety of research and service delivery projects in the fight against infectious diseases, especially COVID-19, malaria, and TB. He's also a postdoctoral research fellow in the Burnett Institute who takes different positions in the institute-led research. He's over 15 years of experience in public health research and disease control and elimination. The second presenter, who is also presenting on multi-stakeholder perspectives, is Monopat Johndeep Paisal. Monopat specializes in infectious disease interventions, health policy and systems research, and policy issues, particularly in Thailand and Southeast Asia region. Her projects aim to minimize malaria risk among forest goers, sustain village malaria volunteer programs, and strengthen the linkage of community-based workers and primary care units in remote Thai settings. She's currently pursuing a PhD at the University of Oxford. Monopat brings a background in policy research. She holds a master's in public policy from the Lee Kuan Yew School of Public Policy, the National University of Singapore, and a BA in political science from Thammasat University in Thailand. Our third presenter will be presenting on GMS-based CSO perspectives. And this is Professor Maxine Whitaker, who I'm sure everybody knows here. She is the Civil Society representative for the Global Fund Regional Artemisinin Initiative 4 of the Greater Mekong Subregion Regional Steering Committee. Professor Whitaker is a public health and health systems researcher dedicated to enhancing health systems and services for increased accessibility and quality. Engaging with global civil society groups like the Rotary Against Malaria and Rollback Malaria Partnership to End Malaria, Maxine's work includes leading community engagement efforts for the Global Fund Regional Grant for Malaria in the Greater Mekong region, with a focus on vector-borne disease prevention, surveillance, and community system strengthening. Maxine is the director of the WHO Collaborating Centre for Vector-Borne and Neglected Tropical Diseases and chairs the technical advisory group at the Western Pacific region of the WHO. She was also the founding co-secretary for APMEN. Our last presenter, who is going to present on a very important topic, which is perspectives from engaging the private sector, which is a big challenge for all of us. Bram leads PSI's disease. He's the project director of PSI. Bram leads PSI's disease surveillance and health security network in Southeast Asia, with a particular focus on leveraging public health emergency operations centers to support sustainable malaria elimination efforts, and is providing technical support to PSI's regional private sector malaria project. Currently based in Laos, he has also worked extensively in West and Central Africa as PSI's regional evidence advisor. He was previously employed at the WHO and has worked as a consultant on geospatial applications, digital health and information systems for UNFPA, Rollback Malaria, MSH, Medicines for Malaria Venture, and other organizations. Perspectives. Is Dr. Win Han online?
Yes, I am.
Okay, can you go ahead then, Dr. Win, and do your presentation on multi-stakeholder perspectives?
Thank you very much, Brian, for your introduction, and I hope everyone can hear me well. So let me share my screen. So, it says I cannot start screen share, or maybe you need to stop. Okay, I can. Okay, I hope you can see the screen.
Yes, we can see it. At least I can.
Okay, great. Or maybe okay, and then sorry, I'll stop share and then share the screen again. Okay, I did. This should be better. So today I would like to talk about the sustaining malaria services and health access in Greater Bengal sub-region, which is about the expanding the role of the community health workers. So as you all know that malaria elimination in Greater Bengal sub-region is ongoing. So the malaria burden declines, and our region aim to achieve malaria elimination latest by 2030. And then when we talk about the malaria elimination, the WHO coordinator for the transitioning from malaria control to elimination highlight the program reorientations, because we need to adapt our strategies and activities to actually host the malaria elimination activities. And on the other hand, everybody knows that all the Mekong countries use their community health worker. You name differently, but each country use the community health worker for the malaria control and elimination. But at the moment, all the countries are now talking and also planning to expand the role of the community health services for several reasons. The first reason is to address the decline motivation and social role of the community health worker, which is stipulated with the decline malaria prevalence in the community. And the other reason is to effectively contribute to the malaria elimination, as well as the primary healthcare program in those countries. So if we look at the little bit details of the CHW program in the region, then we can see there are some differences from different perspectives. For example, in malaria, their roles and responsibility are also different across the region.
Most audio is stopped. Please look into the matter.
Can you hear me?
Yes, I can hear you.
Okay, so I'll continue my presentation. because someone talked, the voice is not coming. Okay, so in the region, if you see, mostly Myanmar and Cambodia are using the CHW model most expandedly, at least for malaria. Laos is also using, but Vietnam and Thailand, their role is somehow limited. But now each and every country are also talking to include additional services in the CHW model with different backgrounds and different reasons. So to assist this process, then we did a kind of health system research, which is the co-designing a CHW model for malaria and primary health care. So we did the systematic review and meta-analysis, as well as the qualitative consultation with different participants in the region, including the community member, stakeholder, current CHW, and also the stakeholder. So if I summarize, then our major findings and recommendations include malaria burden has declined, but malaria is still their choice and their priority. But it is not malaria alone in the service package is not enough. They also recommend to include a number of diseases, including flu, diarrhea, skin infection, tuberculosis, and NTD, neglected tropical diseases.
Host, no sound.
Go ahead. I think somebody needs to mute their microphone when they're not talking, please.
Okay. And the stakeholder agreed to expand the role of the CHW, but on the other hand, they also want to put some restriction in the CHW model. So in this context, we developed the community deliver integrated malaria elimination model that include the intervention for malaria, dengue, tuberculosis, as well as the RTD negative fever and childhood diarrhea. And then we implemented this model as a research in Myanmar back in 2021 and 22. So when we evaluate the findings, that implementation of the CIME model, the expanded model, resulted in 23% increase of malaria testing compared to the existing ICME model in Myanmar. And of course, the cost is more expensive of implementing the SI model compared to the control arm of the ICME model. There are also, we also did the mixed-method evaluation of the model, and then they say like the community member really value the inclusion of the febrile illness management as well as the diarrhea management in the CHW model. But although the model works well, there are also some challenges in the advocacy and coordination because some of the basic stuff didn't aware the integration of the diseases, which we need further advocacy and coordination. We included the assisted referral fee, which were not enough to actually cover the travel costs of the participant. They also requested the additional IEC material for each service package included in the model. And of course, the other issue is stock out of medicine and commodity for each program. And the other reason discussed by the CHW were the data burden, because they are reporting the malaria cases. Now we included additional diseases to the CHW model. So they also need to simplify the data reporting and recording guidelines to reduce the data burden. And when we implement the research, there were COVID-19 and also the political crisis in Myanmar that impacted the activity of the research. So those are the challenges of the expanded model when we implement it. So in summary and recommendation, what I would like to recommend here is like, yes, of course, we need to expand the CHW model because malaria alone, malaria silo program alone is not working, because as you know that in most of the GMS country, the malaria burden decline, and so we need to give some assignment which is really meaningful to the CHW. But we cannot just give the assignment to the CHW. We also need to provide supports to the CHW, which include the sufficient and improved training and supervision, and interrupted supply of medicine and commodities, and the simplified recording and reporting system. Those are the additional things that we need to support to the CHW if we need to expand the CHW model. And in scaling up the SI model, it depends on the health system capacity, also the future direction of the malaria elimination program and universal health coverage. That's why we recommend face-to-face scale of the expanded model with continuous monitoring and optimization. So we implemented this study in Myanmar, but other GMS countries can take the lessons from this trial. So as an integrated CHW model is recommended if formal health system cannot cover all essential health services and area and population. And people, the other country might also think about the CME model that we implemented, and then they can adopt the model with adaptation into their country context. Finally, I would like to conclude my presentation to bring the community voice up front, because when I was in an interview then with a community member, they say like, well, you are talking about the malaria elimination, and then he also questioned back to me like, malaria elimination, whose problem is it? Because as long as I don't get fever, I don't care, because it's you who want to eliminate malaria. So we need to consent and then listen to the voice of the community and then make it on the same page. Thank you very much.
Thank you very much, Dr. Wynne. That was a very interesting presentation. And I think there are other evidence that community health workers can actually improve, can deliver other health services besides just malaria, and that actually keeps them motivated. And also it increases the uptake of RDTs. Malaria Consortium itself did a study in Sagaing province before the coup, and proved that that was so, especially in remote populations. So thank you very much for that. We'll move on to the next presentation from Monapat. Are you ready?
Yes, thank you for that introduction.
Yeah, I think you're muted.
Hi, can you hear me okay now?
Oh, we can't hear you.
Monapat, maybe you need to speak closer to your microphone. It's a little bit late.
Yeah.
Is it clearer?
No, not really.
We can't hear at all, I think, Messiah.
Yeah, Prudence, maybe just for time, as Monapat tries to troubleshoot, maybe we can go to, I think we have Maxine next first, if that's
Yes, I
okay
think
with
if we could go to
with you?
Maxine, that would be great. Yeah.
I'll
Can we wait
troubleshoot with
if I can come
Monapat.
back to you? Yeah.
Yeah.
Can you go ahead then, Maxine?
Professor Maxine, you're on mute.
Yep, there we are. So thank you very much, and thanks for trying to keep time, because I actually have something straight after this that I have to join by Zoom. So I'm going to present on behalf of the CSO platform called Malaria Free Mekong, and I've given you the web address of that for people who'd like more information. Basically, what I'm trying to show on this diagram for the Greater Mekong region are some of the activities that are happening now or need to happen to get to elimination. So you'll see that this group of community health workers, village malaria workers, mobile malaria workers, mobile health malaria health volunteers, malaria post workers, integrated community malaria volunteers. There's a whole range of different ones, as Wen Hanu just showed you. They have to do these additional activities around forest goer packages, targeted drug administration, supporting radical PV cure, integrated packages of services, vector control, mass drug administration, and case investigation, foci investigation and response. They have roles in all of those, around roles like testing, using RDTs, some of them also doing G6PD and trial positions, but often referring people then to get G6PD testing. Treatment at various levels, depending on which country they are in. Adherence support, distribution of long life nets and hammock nets on mass distribution or continuous distribution or targeted distribution. Health promotion activities, case finding, including passive and active case finding, a lot of outreach activities, and as Wen Hanu showed you, some of them are already providing some primary healthcare services. So there's a lot on the shoulders of these workers, some who are government workers, some who are not, some who are paid, some who are fully volunteers, some who get reimbursement for costs incurred. If we look at the table on the right-hand side, you'll see here those workers, what their numbers are in the region. This is the latest data that we could get. I note that the Myanmar data is definitely an estimate across everything. But you can see there's quite a large number of community health workers, and you'll see that split between who works in the community sector, so with civil society groups, and who may work in the public sector. And then the percentage of testing that's done in those sectors, and again, testing, being allowed to test, will depend upon the country they're working in and the percentage you can treat. And again, that's limited in many of the countries in the region. If you look on the left-hand side, you'll see particularly where most countries are really focusing the CSOs, particularly in the fourth grant, is along those borders where there are mobile migrant and ethnic populations, be they cross-country borders or be they cross-district borders. Particularly in Cambodia, there's a lot of forest areas within the country, and there's mobility across those intra-country borders. And again, you'll see here, there's a large percentage of volunteers who are doing that work. These are community volunteers, and you'll see the broad range in colour of different CSOs that are managing those workers. So just 2 case studies to illustrate this work. Recently, I was in Tak province, met this woman who agreed to her photo being shown and her story to be told. What they're doing at the moment, where there's so much mobility coming across the Thai-Myanmar border, the CSOs are identifying where there are new clusters of mobile and migrant populations. And their role, being on the ground and of the community, is to inform the district and provincial health staff. That then activates a whole range of activities. The government staff can then come and test and treat because workers like this lady here are not able to, but they provide the sustained behaviour change communication, the nets, adherence support, and help navigate the patient through the whole referral process if they need, particularly if they need G6PD testing or they have other complicated problems. The government now is also mobilising malaria posts for these staff, and these are co-staffed with the government, so they can do the test and treat, and the CSOs to do the work, behaviour change communication and outreach. And these are popping up where they're sort of popping up where those populations are. So it's quite a lot of flexibility happening now on the border. And the government then also mobilises supplies and commodities. And although there's challenges, they are trying to meet these unexpected caseloads and those locations for services. And it means a worker like this lady here may also have to move where her workplace is from time to time. The next story is around how to sustain the volunteer and community engagement in integration, but through integration of services. So it's nice to follow on from Wen Han U. As he showed, the community data in Laos showed that communities wanted integrated services, particularly these populations who are not being reached well by routine services. The services are not accessible for a range of reasons, not just physical. The qualitative data also showed that the volunteers requested the ability to provide other services. As Prudence says, they were becoming demotivated, they felt hopeless, they couldn't meet the needs of their communities, and there was little malaria. The Ministry of Health showed that there were major other health problems amongst these communities that needed to be addressed, and so did make the decision to integrate the support between ministry and the NGOs and CSOs. That's part of the RI4 funding grant. Some of the challenges that are being anticipated, though, many of these workers, volunteers, had been recruited to work with male forest goers, but now as we start adding in maternal child health and nutrition, we actually need female CHVs. And they're finding it's a little bit difficult to motivate women to actually work in these locations and under these conditions. And secondly, as Wen Han talked about, there needs to be a lot of training, not just one-off training, but they want to have refresher training. These are very brand new skills for many of these people, new knowledge. They need supportive supervision, And they will, as was shown in Wanhanu's work, need the health products and equipment to be supplied and very clearly defined referral pathways. And that's some of the work that's happening now by the two groups, sectors in the ministry. These are some of the challenges, just to finish off, around achieving and sustaining malaria elimination, but also doing it with an equity lens. Of course, P-Vivax management is a problem. Services for these very differentiated mobile and migrant populations, those last kilometre approaches, which I showed on that first slide, preventing the re-establishment of malaria and what the roles may be for workers at the front line, and how to keep the sustainability of these services and some of the issues that Wanhanu talked about. And then also for community-based organisations and civil society to actually be able to use data for decision-making to ensure that the services they're providing and the services the government provide are actually accessible, acceptable, etc. And therefore the role of things like community-led monitoring, having a gender equity, disability and social inclusiveness lens, and making sure that both qualitative and quantitative data are valued and available to help support decision-making. Thank you very much.
Thanks very much, Maxine. Shall we go straight now to Bram's presentation around perspectives from engaging private sectors? Can you go ahead, Bram?
Yes, good morning, good afternoon, everyone. Let me briefly put on my video, and I apologize, I will have to switch it off because I'm getting messages that I have an unstable internet connection. I'm in a guest house at the moment. So I just wanted to say hello and switch off to avoid any issues there. So thank you, Masai, also for sharing my slides. I will briefly talk about PSI's experience working on private sector engagement in malaria service delivery and in surveillance in the GMS, and specifically looking at Laos, where we'll see how these community-level private clinics and pharmacies, because we often forget when we talk about community health workers that these local clinics and small pharmacies run by community members are an integral part of this. So we'll see how they have also become part of the country's strategy for malaria elimination. First of all, next slide, please. A bit of background about our GEMS project, which is funded by the Bill and Melinda Gates Foundation. It's ending now after 2 successive phases, initially GEMS and then GEMS Plus, which stands for the Greater Mekong Subregion Elimination of Malaria through Surveillance.
I don't know what to do.
Please
I think some
turn off your...
people are not muted.
Yeah, please turn off the mute. Thank you.
So PSI, we worked with the national malaria programs and partners in Cambodia, Laos, Myanmar, and Vietnam, applying slightly different models and strategies, also depending on the ability to work with the private sector. But ultimately, the main objective was to engage the private sector providers in order to provide quality malaria case management and report their surveillance data. And GEMS Plus, which is the follow-on phase primarily aimed at transferring private sector network management, including surveillance, to the National Malaria Program and really hand over that network, which at its peak, we were working with over 20,000 private providers across the region. And these included a range of different types of private sector, because there's not one private sector, obviously. And over time, this network was refined and optimized to make sure that we maximized impact in those areas with highest caseloads or with lack of accessible public sector services. So a little bit similar to what we see when we're looking at community health workers. And even during this final transition phase, these pharmacies, clinics, and other private healthcare providers continue to contribute a substantial proportion of national testing volumes and of confirmed malaria cases. And in Vietnam, that was up to 14% roughly of all cases detected nationwide during this 2.5-year period or 3-year period that were detected through these providers. So, and even lower shares as seen in Laos, for example, with about 5%, are still extremely important in these elimination settings where literally every single case counts, right? And it's really important to have very sensitive surveillance mechanisms in order to find those last remaining pockets with local transmission. One key requirement during that transition phase was that private sector surveillance data be systematically incorporated into the national malaria surveillance systems, or into the HMIS, if that's where malaria data is housed, in a way that makes it easy for providers to report cases and for public health authorities to access reliable surveillance data from these networks. And again, without these private sector contributions, there would otherwise be quite a blind spot in that surveillance system and delays in picking up cases. So next slide, please. So how did we go about this? To start, once we had identified and mapped out pharmacies and clinics in these intervention areas, we worked with the national programs to design malaria reporting forms to be used by these enrolled private sector providers. And obviously these were built on or following the national guidelines and aligned with public sector reporting tools, though somewhat simplified. And in Laos, these providers, they're typically small pharmacies and local clinics, also called PPM outlets, where PPM stands for public-private mix, which has also been applied to other settings and other diseases. And one of the first things we then had to do was to define the reporting requirements, obviously, but that was first of all done through paper registers, which had its own challenges, obviously, in terms of timeliness and quality of reporting. So just like pretty much everybody else at the time, this is going back to 2017-18, we deployed a mobile app, initially a custom app, and then a DHIS2 Android capture app for these providers to submit their surveillance data, taking advantage of increasing connectivity and availability of mobile devices among the users. However, even there were still significant challenges associated not just with internet access, but things like the need for compatible devices, managing user accounts, to the ability to update versions. Local languages were not all supported. So it also required intensive training, which was quite demanding and required refresher training and so on. So in response, we deployed more user-friendly options, including social media messenger apps. And well, we're not going to talk about the digital solutions here. It was really interesting to see how there was a strong uptake of tools like Facebook Messenger and WhatsApp, which we found that we could turn these into chatbots that can be used to submit structured data, case reports and other data like stock management data, through a reporting channel, a digital channel that almost all users are already familiar in their own accounts, and it's in local language, and it made it much easier, right? And it showed also how end users want options, that there's no one-size-fits-all solution that you can impose on all users when it comes to surveillance channels. Throughout the process, of course, we also needed to conduct routine supportive supervision and ongoing data quality assessments, which contributed to rapidly improving reporting rates and overall data quality, which was really important because initially there was quite a bit of reluctance among public health authorities and national programs in terms of trust of private sector surveillance data. The going opinion initially was that, well, private providers, they're not trained, they can't, they're not qualified to submit good data, but we showed that it was possible, and that led to a stronger uptake and trust in this process. So next and final slide, please. At the same time as we were working on setting up the provider network and ensuring that reporting was happening, we collaborated with the Ministry of Health, not just the National Malaria Program, but also the HMIS unit, and in Laos, the Food and Drug Department and the Department for Healthcare and Rehabilitation, to enable direct reporting into the national HMIS, which in Laos is hosted in the DHIS2 platform, and which until then, that's a few years back, did not actually include any private facilities or pharmacies. And with PSI pulling out and transitioning network management over to SEMPE, the national program, we needed to make sure that reporting would be sustained and locally owned, within the existing malaria surveillance system. And so that was very much a collaborative effort. It took some time, but in the end, more than 400 active clinics and pharmacies were added to the national HMIS as organization units, allowing for direct provider level case reporting. All were georeferenced, so cases could easily be mapped. And SEMPE also updated their protocols so that the district malaria officers became in charge of PPM reporting and tracking of referrals from private to public sector facilities. And following the transition of that private sector engagement, SEMPE now continues to work with these PPMs and provides training and support with case management, commodities, referrals, and obviously routine reporting of surveillance data. And the map, just by the way, on the right, the red and pinkish dots show cases reported through the private sector network, I believe for the last 12 months. So it continues even after PSI pulled out about a year ago or even longer. We're seeing that this is quite a sustainable approach that's been really owned and fully managed by SEMPE, who also have a dedicated private sector coordinator. We gained a lot of insights throughout the process, and we don't have time to go into all of them, but first of all, we realized and we confirmed that community-level private healthcare providers have a really important role to play and contribute significantly to improved case detection, leading to more sensitive surveillance systems, and in turn become a critical component of the national malaria elimination strategy. We also learned how to activate provider engagement through a combination of strategies. We gained insights into their motivators and the barriers to private sector engagement, and we've documented this in a number of papers. A third, also that suitable digital tools that are tailored to the needs and capability of the providers, combined with the right levels of technical support, supervision, capacity building, are going a long way in improving the surveillance data quality. And as I mentioned, to improve trust in these data among Ministry of Health and partners. In the end, we've seen how we established a solid PPM model that remains active even after the project ended, and how at the same time we work towards incorporating private sector reporting into the national HMIS under that overall transition. And it's important to highlight that malaria here paved the way for expanded disease surveillance through the private sector, not only for malaria, but now also covering private hospitals and other diseases as part of wider integration efforts, moving from largely vertical malaria programming to sustainable integrated approaches, which also includes community health workers, as we've heard, of course, in the last two presentations, alongside surveillance and response, supply chain, other communicable disease control functions, all becoming increasingly managed through more horizontal or transversal MOH units, and thus becoming more sustainable. And with this next slide, I would like to thank everyone, and I'm happy to take any questions at the end of our panel session. Thank you.
Thanks very much, Bram. That's a very important description of how to involve the private sector, and hopefully that can be expanded into other countries, because the private sector, especially in many African countries, actually provides much of the care for malaria, and private sector data is often not included into HMIS systems. Can we now go to Masai, to Monapat? Is she available?
Hi, Prudence. I hope the audio is better now.
Thanks very much.
Really?
Yeah.
Perfect. I'll be sharing my screen next. Apologies. Give me 1 second. I'll share that in presenter mode. Great. Apologies for the technical. Hi, can you hear me okay?
Yep, we can hear you very well.
Thank you. So apologies for the technical difficulties. Hi, my name is Monapat. You can call me Sai. I'm currently working with the epidemiology department at the Moru in Bangkok. And today I'll be presenting actually on behalf of our team who were conducting research in the past 2 years on the project, looking at what expanded roles could be potentially administered in 3 countries, which are Cambodia, Thailand, and Vietnam, for the malaria community workers in the countries. And for this study, we'll be focusing on the results of the, for this presentation, I'll be focusing on the qualitative results of the project from the stakeholder analysis, interviews, and the community surveys that we did with the stakeholders and the communities in these 3 countries. So I think I would like to echo what probably Dr. O was talking about earlier about how the community health workers are a very key component of the malaria programs in these regions in accessing, in providing malaria care for some of the populations. From our previous work, we have identified that the people who are still remaining at risk in the region, in these countries, despite declining malaria, people who are visiting the forests, and some of them might be also mobile migrant populations. These workers may not only be, when they were visiting the forest for different reasons, for livelihood, earning, hunting, foraging, they are not only being exposed to the malaria vectors, but at the same time, these work can be labor intensive. Their nighttime works, which not only expose them to the vectors, but also can sometimes be illegal or based on the activities they were doing in the forest. So this population group may be less inclined to visit a public health facilities for fear of disclosing their personal information, such as their travel history. So having the community-based health workers within their communities close in a nearby health post is key to accessing malaria care. And they have been, so in the past 10 years, they've been key to contribution to reducing the transmission in these areas, and also contributing to the malaria elimination efforts. So based on these notions, we conducted this project under the Regional Admitted and Resistance Initiative Towards Malaria, the RIDE-3, and we're focusing on the role expansion of malaria community health workers, where the presentation today is embedded in a larger project, which also includes reviews of existing program in the Asia Pacific and the online survey of implementers, as well as interviews with them, which were conducted in collaboration with APMEN and UCSF. There was also an implementation study that was conducted specifically in Cambodia to pilot, train, and evaluate the performance of the community health workers. But for the presentation today, we'll focus on the policy analysis and the community surveys of the study. And the photo on the right, were some of the images that were of the results from the landscaping studies, which I'll try to connect back to at the end of this presentation. So key methodology here is to identify, analyze who the stakeholders might be in role expansion. And our main focus is on the malaria community health workers. We want to understand who they are, were they willing to expand their roles, and what support they might need. We also identify some of the other stakeholders, including the communities and population at risk who these health workers were serving. There's also the national malaria programs and the community civil society organizations who are implementing these programs. And at the same time, in all these countries, there are the general health system and the hospital and health centers who are the main care provider for the other diseases and care in these communities. So by plotting them onto like this matrix grid, kind of help us understand a little bit better where their support and influence might be in terms of making decisions on role expansion. And by conducting these studies, we want to understand a little bit better how there might be existing collaboration, training, and supervision among these stakeholders. So we did number of interviews and focus groups with these stakeholders from national, subnational programs, including the international and civil society organizations, the malaria workers themselves, and the communities that we have identified. And these are the sites that we have collected data from in each country. A majority of, in Thailand, it's along international border, and in Cambodia and in Vietnam, they're mostly closer to national parks in the country where populations might be visiting and being exposed to malaria. Important things to note here from our data collection is that majority of our key informants at the policy level are within the Ministry of Health, which might limit the perspectives that we might have got from the key informants who might be outside of the health sector. And in the study sites that we selected for community surveys, these are mainly low transmission areas. So we might be missing chances to talk to more mobile migrant populations that may have been located in a higher transmission places. So here are some of the results. In this slide, we're trying to capture how the livelihoods, healthcare, and policy might have been related and what implications there might be for role expansion. So we want to know what the livelihoods of the people in the forest who are still remain at risk of malaria are. We want to understand how they access malaria care and what other illnesses they might be experiencing. At the same time, we also want to know who the providers are in these communities and how the care is being delivered. For the policy, we're focusing mainly on the malaria programs and the malaria workers related policy. And by connecting these, we want to understand how, for example, when we were interviewing the people who are in these communities, malaria is less of a concern compared to their past experience. And currently, a lot of the populations, especially in Thailand and Vietnam, are more concerned about NCDs, diabetes, hypertension. In Cambodia, febrile illnesses, respiratory, digestive illnesses have been identified as the main concern, and we were whether providing care for these local health concerns, testing, screening, basic treatment for these illnesses might be possible role that could be added on. At the same time, we also noted that the population in these communities are mainly elderly who are still relying on a lot of the health benefits and insurance to access care. So having a strong referral system and the coverage and holistic care for these population group is key consideration for the design of the programs. And keeping our focus on the community health workers, we have learned better that these people are multitasking volunteers. They already have numerous of embedded roles within the communities. The table here is trying to highlight the malaria workers we interviewed in Thailand and how they are beyond malaria. They're also performing other roles. For example, they're already primary care, community-based health workers within the primary care system, and some of them might also take on other different roles, such as assistant to village leader or being representative of the community themselves. So they're busy people. And when we ask them about the motivations and what could be a bit barriers for them to perform additional roles, many of them cited that the contribution that they made, while also receiving compensation and advancing in their career as the community health workers has been their motivations, but at the same time, they were concerned whether they'll be overburdened, underpaid, or even underperformed if they were to perform additional roles. And this is because many of the health interventions might require them to have additional digital skills or devices that they currently do not have. And at the same time, many of the implementers are also aware that for community health workers in these countries, there's currently legal barriers for them to perform testing or screening services. So that has been very well noted by the by implementers. At the same time, I chose this quote here where a lot of the people at the policy level that we interview told us that there might, rather than expansion of roles, maybe integration of role could be one of the potential ways of sustaining these malaria workers and the malaria services in communities.
Monopat, I think that we need to come to an end of your discussion because we don't have very much time. Can we just quickly go through the last slide on the discussion and then
yes. Thank you. I'll happy to discuss this a little bit further, but just on this last slide, currently we're building on from our current project on trying to do more public engagement, policy engagement work where we try to co-design the approaches to sustain these malaria services in the areas where we're studying, especially in Thailand, to come up with how best to sustain these malaria services. And I'm happy to talk more about it or answer any questions in the end of the session. Sorry for going a little bit over time. Thank you, Prudence.
Thank you. Thanks very much. That's very, very important data that you presented there, because it's difficult to sustain the services, I think, particularly where community health workers have limited ability to do their jobs, legal problems, etc. And we're going to have now about 7 minutes, I think, to our panel discussion. So can all the panelists, if possible, turn on their videos, please? And then we're going to ask some questions. And I'm going to take the chair's prerogative to ask the first question. And I think it relates very much to what Dr. Wynne presented. It's to all of you. So in sustaining malaria interventions, how can community empowerment and active participation be fostered to ensure the continued engagement of community health workers and the community itself in malaria prevention and control efforts? As Dr. Wu presented, the people don't feel involved in malaria elimination activities. So how can we get them more involved in those activities? So first of all, Dr. Wynne, can you tell us how you think we might engage them more in malaria elimination activities?
Yeah. First of all, then this question is very important, and also it's very much comprehensive as is required. I think it is the art of the co-designing of a healthcare model, because as we are talking about the community empowerment and also the bringing the voice of the community upfront in the healthcare system development, as well as for the healthcare model development. That's why I think for the malaria, then our research group and also the MORU group and other people have already do the co-designing of the CHW model. And then what we can do is that we can continue evaluating these model to bring another step to the close of the community perspectives. We can continue monitoring their community preference and also their perspectives, and then we can continue optimize the CHW model. So when I say optimize the CHW model, what I'm saying is like we need to provide the services of the community demand as much as we can. Of course, there are limitations. I understand that each and every country have their limitation and policies, and as well as the rules and regulation we need to follow. Of course, we need to follow these rules and regulation, but within the allowance of what the policy scope, then we can do a lot. We can provide a lot to the community so that it stays popular and that the community stays use the CHW model for their primary healthcare. It will somehow support the malaria testing and or malaria treatment and malaria prevention, and ultimately support the malaria elimination agenda of what we want, or what they want. Thank you.
Thank you. And Bram, how do you feel that the private sector providers can be motivated to take part in the elimination efforts?
Well, it's obviously a combination of factors, and as I mentioned, we have done some studies across the GMS countries to look at these motivating factors among providers. One of the conclusions we drew was that it's not about money, it's not about financial incentives, even though yes, we need to be able to make sure that providers maybe some phone credits or other small incentives that allow them to use the reporting tools and to adhere to the timelines and so on. However, what seemed to be the most important factor was their sense of duty towards the community, and they see themselves as having an important role, being health professionals that are embedded within the community to look after their community. And by including malaria into the package of already integrated services that they provide, by nature, a pharmacy or a private clinic is not about one health area or one disease or one specific intervention. It's all about primary healthcare, right? And there, by making sure that they have malaria on their agenda and are capable of recognizing potential malaria cases and know when to test a fever case, that's a very important step, because we've seen that incorrect or delayed recognition and detection of cases can lead to surges in areas where malaria was previously eliminated. So it's really important to sustain the knowledge of the health workers, including private providers, in providing malaria services, especially in these elimination settings where the collective memory and individual memory and capacity to deal with malaria may fade, right? As there are fewer and fewer cases. We've seen this also with community health workers. They say, yeah, I'm a malaria volunteer, but I have very little malaria now. There's also all these other things. So by really making it part of that integrated package and tapping into that sense of community duty, those are just a few of the factors that we've uncovered. And much of this, and I will end on this, was informed by involving the communities, and in our case, the private providers, but also the village leaders and community members very early on in the design process, and really applying human or user-centered design practices to develop the mechanisms, the protocols, the approaches to implement this.
Thank you very much. And Monipat, what do you feel about this particular situation of motivating the community to remain interested in malaria when they feel they don't suffer from it anymore and they've got much more pressing health issues to address?
Yeah, thank you. I just want to build on Pat and Dr. O comments a little bit. I totally agree in that based on our study, we learned that the malaria workers who are within the communities, then with their multiple roles, they're also part of the primary healthcare system, which is where the malaria services will be provided mainly in the future. And having that multiple roles is the best, like tapping into these people are the best probably way forward to integrate the concerns of the communities into the primary healthcare, which from what we have seen is partly have already been done in many communities where they're trying to listen to the communities, what kind of health concerns there is and what kind of services that the primary healthcare units could provide in that respond to the actual demand. So having what I'm trying to say is by sustaining those malaria workers who are also the village health volunteers, for example, that part of the primary care units, that's one way of already sustaining the demands of the communities in the primary health care. And I think what we could do next, or could build on a little bit better, is strengthening that connection between the village health volunteers and the primary health care units, and and at the same time, where if the malaria program it's a separate unit, collaboration between the malaria programs and the primary health care units with the malaria workers and the health volunteers themselves, also with the civil society organizations who might be implementing the malaria programs in the communities, can help really sustain these like connections and service provision that could address beyond malaria issues.
I do think this is a very important point that we should be making, is that at the Ministry of Health level, the coordination between the National Malaria Control Programs and other health programs, particularly the maternal and child health programs, is often a big challenge to get them to cooperate, to monitor and to train community health workers in doing different tasks than just testing and treating for malaria. So, Professor Maxine, I actually wanted to, I noted your point in your presentation that there were mainly male workers who were mobile malaria workers, and that the difficulty of getting females to do the job of community health workers. I think this is a very important point, because it's difficult sometimes when we set literacy levels and educational levels for community health workers. How do you think we can address that problem?
Okay, thank you, Prudence. I'll just pick up again a person that I met who is one of these mobile malaria workers in Cambodia. What she did when she had to travel was she actually had her husband come along. And so she had actually trained him also on some of the things he could support her. And he was happy to go along with her. And that made her able to do her work. So one thing is to think about, particularly as we're talking about putting more load on people's shoulders, that doesn't mean you may need more people. It doesn't mean you just keep putting more and more things on people's shoulders, because as some of the workers said, you might lose your quality, you might be overburdened, you may actually lose your motivation, and that often causes retention issues. So I think thinking about what is the package of workers as well as services is really important. The second thing is to look at how you might be able to combine some of these services in different ways. And there are models. I mean, what we need to do is look outside the malaria world. I think, many of us on this call have worked in many other countries where you've had mobile community workers doing a range of other activities, and there's ways we can support them. And we actually need to get out of our malaria silo, just like we're talking about the government programs thinking about more integrated services. We need to look at lessons that have been learned in many other health programs and bring them to the table. We don't have to reinvent the wheel. And I just want to pick up on that comment about that you made about sustaining communities' interests. It really does depend on which communities you're talking to and which are the workers. So if the workers are truly chosen by the community or of the community and a part of those community structures, they are motivated. And we've got several quotes, I'm sure, from them talking about how they want to serve their community, and that keeps them motivated. Many of the communities in these border areas still have malaria. It's still top of mind, but they also have other needs. And I think it's unethical when we're dealing with very remote populations not being served well by routine services, not having access to private sector, that we should provide integrated packages because they have health needs, not just malaria needs.
Yes, I totally agree with you about that. And I think learning from other countries is also very important. Certainly in Africa, where ICCM, integrated community case management of children, is very common. In Asia, it seems there's a big barrier to community health workers prescribing antibiotics, for example, and antibiotics are very important to control pneumonia, for example. So working with governments is going to be important as well, to bring the evidence to them as well. So Ipsita Palbomik has asked a question to everybody, to Bram, I think, particularly. What kind of incentives are given to private providers? Are there studies on their compliance without incentives?
Right. Again, that issue of incentives, it often comes back, obviously, and people need to be motivated, and whether that's through incentives or through an incentive could also be, let's say, a stick, in the sense that in some cases we've seen that if public health authorities are capable of enforcing the rules and regulations around private sector service provision and reporting, which often exists but are not enforced, and if they can link it, for example, to annual registration and licensing of these private providers, that can help. On the side, the carrot side, let's say, there's things, as I mentioned, you can have phone credits or other small monetary incentives, but they typically need to be small and are not sufficient by themselves. We've also seen that just community recognition and celebrating and making sure that these providers also get something back in return, because they receive training, they may receive branded commodities, a quality seal, because they're part of this program, will also help in terms of motivating them, because it shows them that they can provide improved quality services. In Vietnam, we've worked with the National Health Insurance to incorporate malaria into the package of covered services, which also goes quite a way in interesting providers and communities and reducing certain barriers around malaria service provision through the private sector. And then last but not least, it also goes back to what you just said, is that we're talking about private sector engagement, but it's just as much engaging the public health authorities, because if you don't have somebody at the district health office or the provincial health office or in the national program who is behind this idea and who can drive and link with these providers, especially when there's no more NGO or other partner to support this effort, then that's another important part, because if there's disinterest and lack of trust or inability on the public sector side to engage the private sector, then things will not work as expected. So I put in the chat the link to a paper that we wrote about motivators for private sector engagement in the GMS, motivation to test, treat, and report malaria cases. So there will be obviously much more details in that paper. Thank you.
Thanks very much. I think, Messiah, do we have to come to a conclusion now? As I think we've gone past our time, actually. Is that correct? I'd like to do a quick summary, though, because I think community health workers have played an extremely important role in Southeast Asia in malaria elimination activities. And I think Africa has a lot to learn from what has been done in the GMS, particularly to drive it. But and I think particularly the involvement of both the public and the private sector and the integration of community health workers into the health system are very important factors that we need to consider, as well as whether we should be paying community health workers or not, whether they should remain as volunteers. So all of those questions are things that need to be answered. But as far as surveillance is concerned, I think the community health workers have played an extremely important role of being able to identify where malaria is and how to deal with it at the very district level. So I think, do we have to turn back over to you now, Messiah?
I was going to say we actually have about 10 more minutes, Dr. Prudence. It's really up to you.
Okay.
There's 2 questions in the Q&A.
No,
right now.
that's fine. I thought we had to finish at 7 o'clock. Sorry.
Oh no. Yes, we have until 7:20. I think your time.
Oh, okay. That's really great. So there is another question for everyone.
Sorry, I'll just have to leave. I did have to leave at 5:10. So thank you. I'm just answering something in the chat in the Q&A. Sorry. Okay. Thanks a lot.
Well, thank you very much, Maxine, for your contribution. And, you know, the CSO platform is obviously a very important means of coordinating the activities across all the countries, and with a particular focus, obviously, on the community level. And if we don't focus on the community level, we'll never be able to eliminate malaria. So I think that's a really important part of your job. Thank you very much indeed for taking part. So Salahuddin Khan has asked a question. They have piloted the ICCM approach. I'm not sure if everybody knows what ICCM stands for. It's Integrated Community Case Management of Childhood Diseases. So it's a focus on malaria, pneumonia, and diarrhea, and sometimes screening for malnutrition. It is important because the other diseases focus on children under 5, and in Africa, that's been a focus of only children under 5. Whereas in the GMS, we obviously focus in malaria on all age groups. And it's quite interesting what has come up in some of the discussions that have been presented to us today, that the non-communicable diseases are becoming very important in the GMS and are important to community members. So when we're talking about ICCM or community-based services, we have to think of what those services are. So Dr. Salahuddin has said, hi everyone, they've piloted ICCM in 2 endemic malaria districts and they're getting quite good results. While analysing data, it shows greater proportion of female and children patients as compared to male and the adult population. Further, pregnant and lactating mothers are reporting quite high as compared to public hospital data. The major challenge is the sustainability of this service provision to communities. How can the problem of sustainability be easily solved? And could you please explain it from your experience? Because I think sustainability is a big problem, particularly when we're asking community health workers to do many different tasks. How can we sustain their ability to do those tasks? And should we be paying them? So, Dr. Wynne, can you give your opinion on that?
So thank you, Dr. Prunan. As you explained, ICCM has been proven to be effective in many African countries, not in one country. So it has been proven to be effective in addressing those diseases of childhood illness, like the malaria, pneumonia, diarrhea. In some countries, they also include the nutrition program. And how can we sustain it? So it depends on a number of factors. The health system of each country and the community demand in each country, as well as the policies and regulation in those countries. So as I already commented before, then what we can do is like we can analyze the existing ICCM model in the particular country context at a particular time point, and then we can modify the ICCM model based on the community demand and based on the upcoming new technology and strategies, and also based on the policies and regulation. And then we can frame. Maybe you can provide a new names, or maybe you can provide as the same names, the updated or the improved ICCM model, which we can bring more closer to the community. So in this way, you can sustain the model, and then you can sustain the community interest in those countries.
Yeah, thank you. And how about you, Monopat? How do you think that we could sustain these services?
Yes, I think two thoughts that come to my mind. I think that's a very important question, like how could the care be sustained in these communities where there's already declining funding to support the provision of services, and also maybe diminishing interest among the providers themselves to also provide care for malaria. I think two things for the additional services that could be provided. We have also, like Dr. O said, we have from our landscaping study where we did under this project, we have identified many countries that have done ICCM, mainly in Africa, but in Asia Pacific, there's also elements of ICCM that's been implemented in other Asia Pacific countries that we could definitely learn from as GMS region to understand how those combination or integration of care could be provided. At the same time, from bringing notes from what you mentioned earlier about actually the people who are receiving care in these communities, they're not only the people who are malaria patients, but also their families, so the mothers and children or the elderly who were staying at home. So when we conducted our study, we also get their responses on what kind of health concerns they have. So we kind of got a lot of responses and concerns on diabetes, elderly care, some other illnesses that are concerns not only for the people who visiting the forest and get malaria, but also their families. So that's identifying those concerns and link that with the primary healthcare system again, I think is crucial to sustainability, and having those malaria workers who currently probably are only providing only malaria care, and whether they can be tapped into leveraging information or referral system of those family members into primary healthcare system could be one of key service that could be explored. And my second thought on sustainability is that whether when we're sustaining the malaria care, whether we're sustaining the people who are providing the care or the care itself, I don't think there's either. It's not really an either a yes to people and not no to the services. But we've learned that maybe in the process of integration and declining malaria, those services are being shifted from maybe community-based to more facility-based. So the key is that when we're shifting that to the primary care-based services, that we don't really lose the people who have access to these populations group. And that's why the malaria health workers are so important in linking that referral system between the population at risk and the primary healthcare providers. Hence, I think there's two prongs. So one is that even though the cares currently might be in the future provided by the primary healthcare system, but having that linkage between the patients and the primary healthcare is important, not only for malaria, but also for the other health concerns that they have.
Okay, so you're saying that it might be that they would have more a role in education of the population to seek healthcare when they need it in the more formal health system rather than providing it themselves. I think evidence from many areas where there are remote populations that actually that's one of the problems of accessing healthcare for remote populations. And again, you know, how much can we expect a village health volunteer to provide extensive services, like, for example, if we're talking about management of diabetes, for example, or even HIV, what can chronic diseases, in other words. So what can be their role? Would it be mainly a health education role, or would it be mainly a provision of actual treatment or monitoring or directly observed therapies, etc.? So I think there's a lot of discussions that need to go on, not only at the community level, understanding what the community itself needs, and also what the government is willing to actually allow community health workers to do, and in where community health workers can be most useful. And one of the problems that arose in our project in Sagaing when we introduced ICCM, we compared areas where people were able to prescribe antibiotics and areas where people were not able to prescribe antibiotics. And it was found that in the areas where people were able to treat other diseases, people turned up with fever much more commonly, so that actually there was more malaria treatment where community health workers were able to treat other diseases besides malaria. And one of the main problems was actually people completing referrals. And I think that's a thing that we have to address in the future. So I think, are there any other questions in the Q&A?
There's one more question, but I accidentally moved it to answered because Professor Maxine gave some insights into where you can look for more information. But I don't know if you'd like to pick it up for the panel to give it a try as well.
Okay.
It's in the answered one from Alia Jabin.
Okay. Can I see it? Can you tell me what it is, Massa? Who was it?
I can read it out for you.
Can
Sorry,
you read it out? Okay.
Please share experience if someone has worked for malaria control in hard to reach area where population is scattered and there's not easy access to healthcare facilities. Relatively similar to your discussion in the previous question.
Yeah. Dr. Wynne, did you hear that question?
Yes. So, for example, in Laos and Cambodia, they have a special types of community health worker, which is called a mobile malaria worker. They particularly train those mobile malaria population who has some education background, who has some motivation to particularly address those hard to reach population, or those mobile population, to particularly address the malaria cases among these people. In Myanmar, we also have CHW, which particular focus on this kind of mobile migrant population. So we call the WhatsApp provider. So I think BSI also did this in Myanmar as well. And so we also have a special kinds of provider for special population. In this way, we can address the malaria problem to the mobile migrant population of forest goer. Of course, the malaria is a rural disease, and so it is always hard to reach even to one village to another in the GMS. So yes, that's why this is one of the reasons that we have the CHW. If it is close to the health center or if it's next to the hospital, then the patient can just go to the hospital or the health center and get treated there.
And Monipat, have you any comments to make about that? Particularly accessing remote populations.
Yeah, I think maybe a short one, because based on our result from the community surveys that we did in Thailand, Vietnam, and Cambodia, the study sites are mainly in low transmission areas, and there's fewer mobile health workers in those areas, particularly in Cambodia, where the number has been declining. The MMWs has been transferred or shifted towards the village malaria workers more. They still provide malaria care, but they're more passive in their care provision, so they may not travel to the forest with the forest goers to administer testing or treatment as they were in the past. However, I believe in a higher transmission area, for example, in Thailand, if it's along the Thai-Myanmar borders, there are currently more mobile workers that are particularly providing services to non-Thai populations in those areas. So there's been initiatives to increase the number of those workers where it was needed. But we haven't really observed that so much in the low in transmission area in our study sites.
So Monipat, I wanted to ask you, in Thailand, I think community health workers are allowed to test but not allowed to treat. Have you done any research to look at how many patients who are found to be positive for malaria actually go to the public health sector to be treated?
So according to the, I think, guideline for Thailand in terms of malaria testing and treatment by the malaria post workers, so there are currently two cadres of workers. One is the malaria post workers who, if already been trained and properly supervised, they are able to provide testing with RDT and potentially also treat with anti-malarials if there's an anti-malarial treatment with them. However, the study sites that we can, and also there's the second category, which is the village health volunteers, which are a bigger group of volunteers who are employed under the primary healthcare system. Some of them may be able to test for malaria if they were being trained for the role, but many of them may not be able to provide treatment, and their roles mainly are to refer suspected cases to the primary healthcare facilities or community hospitals. So I'm sorry. What was your second question again?
I just wondered if you'd looked at how many people who were referred from the village health volunteers actually went to access treatment.
Yeah, I think that's a very important question. According to the guideline, if the person who is being tested positive with malaria at the community level or by the malaria post worker, they have to be referred to the hospital for treatment and further and diagnosis that are beyond RDT. So based on our study site, we didn't specifically collect data for that, but according to the guideline, when we were talking to the community health workers, that were the tasks that they need to adhere to. However, when we're collecting data, there's so little number of cases in the communities, so we weren't able to collect that during our time of data collection. But I think it's important note on what could contribute to maybe building an evidence for putting a case on like how these workers were able to actually refer patients in the future. I think that's something important to
I think that's important. Thanks very much, everybody. It's really been a very interesting discussion for me, and I think community health workers have as I've said before, have been fundamental in malaria elimination activities in the GMS. And I do hope that many African listeners that we have to this will be taking this on board, because I think that access to early diagnosis and treatment really addresses the parasite load within the communities and helps to break transmission. So thank you very much to all of the presenters. I think that was very, very interesting. And I think that the expanding role of community health workers needs to be thought out very carefully. It needs coordination within the Ministry of Health, within the district levels and within provincial level departments as well, and to think exactly what community health workers can do, and not to overburden them, and to think about whether they should be remunerated or not. So those are all important questions for community health workers, and especially for improving access to care for many remote populations. So thank you everyone very much for that. And it's been a very interesting session.
Thank you so much, Dr. Prudence. All right, I think we'll be moving on to the next section just for timekeeping. Professor Richard, do you want to take over in introducing the group a little bit?
Will do. Thanks very much, Prudence, and all the speakers. That was really good. A lot of food for thought. Our next session is a little bit related, because we've talked already in the meeting about plans to develop guidelines for assessing the performance of community health workers for their malaria activities. So we're going to hear from Luigi Nunez from PSI. So he's Digital Health and Monitoring Advisor for Malaria and WASH. And because he's based in Washington, DC, he's recorded his talk, but we're going to play it just now. And then we'll have a poll for people who are interested to contribute to this guidance.
Good morning, good afternoon, good evening, everyone. My name is Luigi Nunez. I am the Digital Health and Monitoring Advisor for Malaria and WASH Programs at Population Services International, PSI. Happy to be here to speak on behalf of the Community Health Committee for the Rollback Malaria Surveillance, Monitoring, and Evaluation Working Group. Happy to be here presenting alongside my co-chair, Richard Maud. And today we'll be talking about a guidance tool that we are working on with the working group on how to measure the performance of CHWs as it pertains to malaria programs. I'm based in Washington, DC, and I apologize for not being able to be there with you all, nor to be able to give this live, but I'm really glad to be here nonetheless and to give this presentation. So why is this being put together? There was a need that was identified during the working group around challenges being had across national malaria programs on how to measure the performance of community health workers, specifically as they are working on malaria. There's a lot of guidance out there on how to measure CHWs as an integrated program, thinking about ICCM, but thinking about the different components as it pertains to malaria and the different activities and actions that they can be taking. There isn't much out there. And so this came up as a need for the working group, and that's the objective of this tool. It is meant to be a global guideline tool, of course, meant to be tailored to the local context, and it would only include malaria-specific activities and indicators. So like I said, it would exclude indicators that pertain to ICCM as a whole. And the target audience are those who are implementing CHW programs, specifically as they pertain to and include malaria. That includes government and non-government sectors. There has been work done so far this year. We held 2 online meetings, one that accommodated the time zones for Asia, Pacific, and East Africa, and another that accommodated the time zones for West and Central Africa, as well as the Americas. We then had a 1 in-person meeting at the ASTMH this year, held in Chicago. And at each of these meetings, there were lots of discussions around the tool itself and writing, starting to put together what we will be writing as it pertains to the sections and categories. At APMEN, we talked more around also the inputs into the document and questions that I'll show in a bit. For 2024, we are focusing on writing. We want to break out into writing groups, start getting those sections outlined and written, as well as having additional meetings as needed, and hoping to complete this by September of 2024. We know that CHWs do so much work. And there are so many indicators to measure each of those activities. And so the way we are organizing our thoughts and the content of this tool is to think about different categories and outlining and bucketing activities and indicators into those categories. During the online sessions, we used Miro, an online whiteboard, to capture information and have participants and attendees write in real time ideas of activities and indicators that they know are happening under each of the categories. You can see the categories in the first column. I'll show them in a bigger picture soon and talk a bit more through them. And through this, we were able to also get some individuals to write, to volunteer for writing some of the preliminary writing teams. At the APMEN meeting, we had some discussions on some really important questions. For example, why was ICCM excluded? It was understandable that some indicators like diarrhea were excluded, but why ICCM as a whole? And again, remembering the scope and the objective of RBM and the committee as a malaria-focused entity. How is this going to be presented? There was an idea around it being an addendum to the surveillance manual by WHO, and how this be framed beyond the malaria space, if at all. And then there were great reminders and recommendations to look at indicators and populate them from existing tools like the RBM handbooks and the WHO Surveillance Monitoring Evaluation Working Group reference manual. And then looking at existing activities, for example, the PMI Impact Malaria, and they develop a framework around measuring the quality of care of CHWs as it pertains to malaria activities. And thus, with all that, the guidance document that we're looking at right now, the way it's being laid out is about contents, acknowledgements, glossary, executive summary, some information about the guideline, an introduction, and then the real meat, going into each category and outlining and writing about those different activities and the indicators particularly on how might you collect them and the information around those indicators. Going back to the categories that I spoke to earlier, this was the list of categories that we proposed to the online working groups, and that was refined a bit during that work. The categories so far are health promotion and education, prevention, vector control, surveillance, case management, administration and logistics, and then recording, documentation, and regular reporting. Many of that aligns with the categories that exist already in many different documents. In the second column, you can see a list, non-exhaustive list of malaria activities done by CHWs. These are actions and activities, for example, performing IRS or giving ITNs, counseling individuals, promoting ITN use, giving IPTP, PMC, and SMC. And thank you again to the individuals who volunteered to write some of these sections based on your immense expertise. And with that, this is my final slide. I'm really happy to have given this, and I'll hand it over to Richard and the others there with you. Thank you again, and have a good rest of the meeting. Cheers.
But thanks to Luigi for recording that. So as you've seen, we've started work already. We have some people who've committed to contributing to the writing. We have a list of volunteers who are also interested to review guidance as drafts are prepared. But we're looking for more people to help. So we're going to hopefully make this work. We'll have a poll that pops up on the screen to gauge interest. If you're interested in contributing to this, It's a partnership activity between APMEN and Royal Bank Malaria. And hopefully you should see some questions. Yeah, okay. So please feel free to complete. So if you've got any questions for clarification, please put them in the chat and I'll answer where I can.
And maybe I'll just let people know as well that this poll automatically records your responses based. So we'll have your contact information based on the Zoom registration you used. So I'm hoping that you used your primary emails for your registration, because I will be contacting you again to coordinate the writing team establishment through that contact information.
Thanks, Maria. We're going to leave this up for one more minute and then we'll move on to the next session. You can't finish this or you can't get it to work, you're welcome to send us an email as well if you're interested to participate. Marina, is there a way for us to keep the pod running while we move on? There's people still filling it in.
I might have phone answer that actually. Phone.
Would you like to stop there? Or
yeah,
No,
maybe leave it running for a couple more minutes and we move on to the next.
yeah, I will end the poll.
No, phone. Can we keep it running in the background while we go on to the next section in case people are still filling it out?
Yeah, got it.
Okay. So let's move on to session 4. Okay, so this is important session about what might be a new concept for some of you, which is geo-enabling malaria interventions. So we have a set of presentations and then we have 10 minutes for Q&A at the end. Our speakers are Anouk Massoud, who is a geospatial health consultant from UNICEF. We've got Dr. Siv Silvanaroth, who's Malaria Program Manager and Chief of the Technical Bureau from CNM in Cambodia. And then Sazid Ibn Zaman, who's a GIS specialist and the Group Mappers lead for my own team in Moro in Bangladesh. And then Steve Ebner, who's the technical lead for the Health Geolab group, also in Epidemiology Department at Moro. He's based in the Philippines. So we'll go to Anupma first.
Thank you. Can you hear me okay?
We can, yeah,
Thank
great.
you, Dr. Maad. Okay, cool. Well, thank you for the introduction, Dr. Maad. Good afternoon, everyone. My name is Anupma Sood, and I am the Geospatial Health Consultant at the Digital Health and Information Systems Unit at UNICEF headquarters. I really wanted to thank you for the opportunity to present today. And in the next 15 minutes, I'm just going to be introducing the concept of geo-enabling the health information system and the components that are required to be in place for its sustainability. I'll also touch upon different use cases of geo-enabled HIS, and in particular, go a little bit more in depth about digital microplanning. So without any further ado, we can get started. Next slide, please. So let's start at the very basic definition of a health information system. Essentially, a health information system is a system that's used for storing and managing health data. And health data refers to patient data, immunization, vaccines, health facility information, etc. One of the important things to note here is that HIS is a much broader term than HMIS or LMIS, all the systems that you can think of in the health sector. HIS essentially encompasses all of these systems. And why do we need an HIS? Essentially, it allows us to make decisions based on evidence and data and helps us resolve public health issues. It also helps us improve patient care and service delivery, and of course allows for more efficient management of resources. Next slide, please. A geo-enabled health information system is essentially when you add the power of geography and time to its business processes. There's a quote on the screen which says, everything happens somewhere at a given time. Now, can you think of a piece of data in the health systems, within the health information systems, that does not either have a spatial or a time component? I mean, everything in the HIS has a spatial or a time component. Thinking about patients, they are in a particular place at a particular time. Same with health facilities, same with vaccines, and so on and so forth. So what's the benefit of the geo-enabled HIS? It just provides a more systems-based and a comprehensive approach to solving public health problems. And we'll actually see some use cases of a geo-enabled HIS in the next few slides. Next slide, please. So this slide really shows what the vision behind geo-enabling is. On the left is our goal is to go from the left to the right. On the left, we see digital systems, which are generally within the health sector in a country. So think about LMIS, think about electronic medical records, HMIS, and all of them have their own geographical component as the foundation. Now, what we want to move towards is essentially the right side, where we are hoping that all of the foundational elements are all the systems in the health sector are built on the same foundation of geography. So all the systems will use the same geography, will have the same admin boundaries, which essentially will reduce cost and duplication, and will also make the systems more dynamic and more responsive. And in addition to actually making sure that the cross-sectoral collaboration will be more. Next slide, please. So this slide just lists the different use cases for a geo-enabled health information system. What the geo-enabled health information system can do really well is locate. You can locate people, so you can map population demographics and dynamics and help us identify the underserved communities. You can also locate health infrastructure and figure out how accessible they are to the population in the catchment area. And of course, that can also inform what communities need to have mobile or outreach sessions, the ones which have limited access to health facilities. And the last one is it can also geolocate health force and we can optimize health workforce distribution based on where there's more need or based on where there's more population to be served. Next slide, please. Some more use cases for geo-enabled HIS systems. In this particular scenario for mapping malaria cases, we can actually identify hotspots or regions with high transmission rates, and which will allow us for targeted interventions, such as focused distributions of bed nets or focused educational campaigns, ensuring resources are used where they're most needed. We can also respond better to outbreaks and emergencies. So in the event of a malaria outbreak, a geo-enabled system can quickly identify the affected areas and enable a rapid response, which is also effective and efficient. The last one here is geo-enabled microplanning, which I'm going to delve into a little bit deeper in the next few slides. But before that, let's look at the HIS geo-enabled framework. Next slide, please. So this slide shows the 9 components that are required to be in place for an HIS to be considered geo-enabled in a sustainable way. All of these components have benchmarks associated with them. I will not go into detail just in the interest of time. This framework is from the guidance on the use of geospatial tools and technologies in immunization programs. The link to this guidance is provided in the last slide on resources, and I'm hoping that these slides will be shared with you so you have access to these links. So just talking a little bit about these components. While most of these components need to be defined at the level of the immunization programs, at least 3 of them need to be defined or need to be common across the health sector. And essentially those are, we need to have master lists for all the geographic objects which are core to the public health systems. So we're talking about health facility registers or master lists, we're talking about communities, settlements, admin boundaries, reporting divisions, etc. We also need to make sure that the geospatial data specifications, standards, and protocols are in place. And lastly, we need to make sure that policies need to be in place which support and mandate the use of these specifications as well as the use of these master lists. Another thing I want to mention is that this framework is also aligned with the UN IGIF, or Integrated Geographic Information Framework, which is essentially providing, which provides a guide for developing and maximizing geospatial information management in countries. Next slide, please. Actually, I'm going to skip the next 3 slides. So this just lists the benchmarks for stage 1, which is the institutional framework. Next slide, please. Now this slide has the benchmarks which are for stage 2, which is standardization and technical capacity, and the stage 3 and 4. Next slide, please. And this lists the benchmarks for the last 2 stages. I included the slide acknowledging that it's dated. This is a situation analysis of geo-enabled HIS systems, or a situation analysis of HIS geo-enablement in 13 Asian Pacific countries from 2017. And this is done across the 9 components that we just saw in the framework. And in fact, Steve Ebner, who'll be presenting after me, was one of the primary authors for this assessment report. So again, acknowledging that a lot has changed since 2017, but I think it's important to present it. And the picture may look a little bit different now. But regardless, let's take a look at it. So if you just look closely, we see that in our region, we have adequate technical capacity. We also have access to GIS software and capacity to use it, of course. And we are also using maps, although there's very limited spatial analysis or modeling that's being used. Where we see a lot of reds is essentially in policy and in the resources for sustainability. So just something that we need to keep in mind, if we are going to invest in geospatial tools and technologies, policies must be in place, and sustainability is definitely key. And of course, if the policies are in place, they will help with the sustainability aspect. Next slide, please. So getting into microplanning, geo-enabled digital microplanning in particular. I think everyone here knows about what microplanning is, but just to give a definition, it's a set of decision-making steps or tools that ensure that the immunization services reach every community and can be used to identify priority communities and address barriers to access and utilization, and eventually develop work plans that are with community-sensitive solutions. Now, geo-enabled digital microplans is essentially adding the use of geography to the health infrastructure and putting it in place to support the service delivery, planning, and monitoring of campaigns. Now, going back to our vision of, I think someone needs to mute their line, please. So going back to our vision of geo-enablement, the foundational layer of geography can be built such that it can support a wider ecosystem of digital solutions. And that's what you see in the, in color in blue and green at the bottom. On the right, you see the Reach Every District microplanning cycle. It lists the different steps that are for creating geo-enabled microplans. Now, Reach Every District, or RED, is a strategy, is a WHO strategy to achieve a goal of 80% immunization coverage in all districts and 90% nationally in the WHO member states. And it really focuses on enhancing and building national capacity from district level up to maximize access to vaccines for everyone. Next slide, please. There are several steps to producing geo-enabled digital microplans. So first we get the spatial information on population distribution. We locate the health infrastructure. We also consider the connecting environment like road networks or means of transportation to figure out access. We create catchment areas of health facilities. We locate who the target populations are within those health facility catchment areas, which will also give us who are not in the catchment areas. So we'll identify communities that require outreach or mobile strategies and optimize locations of service points to ensure that we have good access for all the populations surrounding the area. And eventually we can support planning and logistics for mobile and outreach activities in a much better way. Next slide, please. So what are the benefits of geo-enabled microplans? Again, as we mentioned earlier, it's easier to identify vulnerable and under-immunized population who may not have access. You can also estimate the population by using high-resolution satellite imagery, and this can validate the census data or even augment the census data, which may be old in a particular country. Gaps in service coverage can be assessed easily by doing an accessibility analysis of the health facility. And eventually this leads to strategic planning for health interventions, and resource allocation is optimized and maximized. And all of the above leads to strengthened accountability. Next slide, please. So we already talked about sustainability a little bit. We have to make sure that the foundational elements are in place. So essentially the 9 components we talked about, which are part of the HIS geo-enabled framework. And especially the 3 that I mentioned that must be common across the health sector. So again, reiterating that, geospatial data protocols and standards, master lists and policies to mandate the use of these standards and protocols as well as the master lists. And one of the most important parts for sustainability, of course, is that Ministry of Health owns the process and also ensures that health workers have the capacity to uptake geospatial tools and technologies. Next slide, please. Thankfully, there is a great amount of guidance that's available to us on digital microplanning. There are a few links here. One of them is the geo-enabled microplanning handbook, which was released earlier this year by WHO and UNICEF. Another very important resource is the one I mentioned before, which is the guidance on the use of geospatial tools and technologies in immunization programs. That's the guidance that contains the HIS geo-enabled framework, the 9 components and their benchmarks. And the final one is about investment planning. I think this is my final slide. Again, thank you again for giving me a chance to present. And I'm passing it back to you. Thank you, Dr. Maud.
Thanks very much, Anna. We're going to take questions at the end, so if you can put questions in the Q&A. We're going to next hear from 2 countries, examples of this application for malaria, so digital microplanning for malaria, starting with Cambodia with Dr. Siv Savanaroth. Dr. Siv, you're welcome to start.
Yes, thank you very much. Do you hear me, Richard?
Loud and clear.
Okay, thank you very much. I am Dr. Siv from the National American Program Cambodia, in charge of the malaria program manager. So today I want to share you one of the link of the MIS to the stratification by using the geo-enabling data. Can you show me a slide, please?
Oh, Professor Siv, Dr. Siv, I don't have the slides, your slides on hand. I think Pengbi is
So
on
you
call.
want me to share?
Yes, is it possible? I don't have the slides from you at the moment.
Okay, sorry. Do you see my slide?
Yes, we do.
Okay, there is a presentation mode or?
Currently, no.
Okay, so I'm going, you see my slide, right?
Yes, it's perfect.
Yeah. I'm going to talk about the geo-enabling development of malaria intervention, especially the how to certification the malaria risk in Cambodia by using that data and method. My introduction here, we have in order to make the efficient target strategy for the intervention, especially malaria elimination in Cambodia, in terms of provide vector control, in terms of provide the surveillance to the subnational level and also the community level. We need to have a clear guidance of the risk belief or risk foresight that need to be the place for implementation. In order to have this, national program has been set the GIS map to geo-enabled for micro planning in order to provide the malaria program strategy. And the more important that I want to tell you today, I have been heard from previous speaker and also this morning that we have a lot of excellent tools that can be help us to pinpoint the implementation. But the more important of the tool is where the data come from. and the data that come to the system, it's accurate enough to use it, or the data that we have here is comprehensive, and also the data has been go through the right direction and also in the right geographical area. So in order to have this, we have to have concrete data in terms of health facilities, number and list it. And we also need to have a good coordination of each of health facility and community network, and even the village base. And we need to have the population size in the village precisely. And we also need to have other support data in terms of malaria transmission burden, like forest cover data. So I just give you one example of Cambodia, how we get data quality, and especially for the geo location of the village opposite intervention. So you see here in the picture here how we have set up the new technology and even the fast and the low cost in order to provide the real geographical in the real map to the whole country. Like in here, we have been do with 10,000 more than 1,000 villages and 820 health facility, and also 99 district that we can spend only around less than 2 months. We can collect all the GPS coordination, and we also can have a precise location that has been explored so far. So the is the one that's more important than the robot system. Even you have a robot system, but the data that have in the system is not really accurate. The implementation could not be effective, especially for malaria elimination. And here you can see that we have 2008 data for village-based data, but after we has been explored the new strategy in 2021, we have the ability to update the village-based and foresight intervention is accurately and the whole country. And you can see the changing of the dot, mean that the changing from the previous 2008 routine data and to the update after our exercise. Here, where is the data quality and correction and collection that we has been done so far? We need to have the annual parasite incident. We need to have the distance of each point of the village to the access health facility in terms of provide treatment, and we need to have the population size in each village. So all this has been collected by using, you see example here, by using the mobile and tablets system that our health facility on the ground can really to answer very quickly when there is something has been changed, in order to tell us where we can provide our intervention. And this, beside on that, there is one more challenge that we has still has trouble as well, because malaria is linked to forest. So in terms of the malaria burden that have been collected through our system, we need to have the other information like the forest coverage in the country. Usually, last time we used the image from the satellite image from ESA that has been the support from our Moru collaboration. But however, the data in 2019 And but in recently we get a new one from Moru as well, 2021 data. But however, the forest coverage is more important because one of the factor that can influence to the transmission. So forest data is also one of the most important. But in order to use the data from the forest precisely and effectively, we have do different methods in order to see what is the link between the forest coverage and our village base. So you see the right side down here. We have design boundary of the village by using the T-cent method, but actually it is not really so comprehensive as you can see that. So we currently has been changed to select the population village size risk by using the boundary of the radius of the forest in order to make sure that each village is covered with the forest with the really precise with the 5 kilometers radius of the total size. As Cambodia right now is around like that. So our marine information system has been do our certifications in 2021 based on what has been explained so far. One is the average of the annual parasite incident, and the second thing is the proportion of the forest coverage, and the other one is the distance of the services where the village need to be people can receive services. So by all these the strata data, we can plot in in our scoring metric here. So currently we are the stratification our risk based on the 5 category from 0 to 4, and by include this. You can see here the results from 21 that we had in the village certification, and compared to the 2022 the village recertification, you can see that that is the data has been flexible change according to the real annual parasite incident and burden, and also with our method here. You can see that there is a precise burden that has been identified in our MIS database that we can see and also can focus where intervention should be provided. In here, as I mentioned at the previous slide, our exercise want to target, classify the risk strata in order to provide intervention, because you know that there is a limitation of the provide tool for intervention like BANET, and also the money for civil system. So we need to prioritize what is the most risk strata that should provide the BANET, and which strata we need to provide community intervention in terms of deploy community network, village marine worker, and mobile marine worker. So this is our certification exercise. It's a key to provide our focus where interventions should be deployed, and what strategies should be provided in order to save our resources, to save the money and time, and also effective. And so in conclusion, I just want to highlight again that data quality is a key of accurate or micro planning. It's the robot system is not enough. You need to have accurate data, accurate geo area like the GPS, and you need to have the full information of the population and full information of the forest in terms of forest coverage. And all of these you can produce certification that answer the implementation to the program very effectively. And however, the certification has been done during the malaria burden in Cambodia still high, let's say 21, and now our malaria in Cambodia is very start to be low. So we have thinking about how to change our certification by changing the design, use case-based data rather than use belief-based data, and also to see the soil transmission. And we will focus on forest coverage, and we will consider on the entomology data to be included, because in order to maintain zero malaria in our village area, especially the POR, prevent or re-establishment, the entomology data is more important as well in order to make sure that where and what intervention should be prepared and what is the health system should be covered in that area. So I think that this is all my presentation. Thank you very much.
Great, thank you very much, Dr. Siv. So we have some questions starting to appear, but we'll do them at the end after all the speakers. We'll go straight to Sazid next, who's going to talk about Bangladesh.
So can you hear me?
Yeah, Sazid, but we're seeing your presenter screen.
Yeah. Great.
Sazid, you might be on mute. Sazid, you might be on mute. Can we go back to the first slide and maybe restart? Sazid, Richard, do you hear me?
Yeah.
Do you hear Sazid?
Sazid is stuck on mute right now.
Okay.
So
I think there might be some technical difficulty.
yeah, he's not able to get it off mute. So we're going to go to Steve next. Can we stop Sazid's screen sharing? Right, thanks, Steve.
Okay, thanks. So I'm gonna jump in before, okay, stop my video as well. Here we go. Hi, everybody. I'm gonna jump in before Sazid, just to talk a little bit in the continuity of the previous presentation about the way the process is actually implemented for enabling the health information system in general, and also program-specific information system like for malaria, and to talk about possibility to conduct not only an updated version of the assessment that Anu presented earlier, but also look at working together for developing an action plan that could help countries to enable their health information system and filling potentially existing gaps. Just few things I wanted to mention in relation to what has been presented earlier, because mainly examples that are presented are linked to the use of the geographic information system once you have a good geospatial data, but the geo-enablement of the HIS, so the proper integration of the geographic and time dimension into the information system, also helped the contextualization of data from different sources in both space and time, which is very important from a surveillance perspective. It allows also to use a geographic object as the command link between different data collected by different sources. So in theory, this is what needs to happen behind any dashboard, especially those that are meant to be dynamic on the long term, to avoid for someone having to manually enter the information. And then also it facilitates trend analysis, right? I mean, we have seen the evolution of some data for Cambodia by Dr. Siv. Geography evolves through time. Malaria evolves through time. So there is really, it's important to be able to capture this properly. And so how do you achieve all of this in a sustainable way? So this is through the geo-enablement of the health information system. Just also wanted to mention that's actually a visual representation of the three documents that Anu presented earlier. So the HIS geo-enabling framework is used not only by UNICEF, Gavi, and WHO, but now also by the Global Fund to support the management and use of geospatial data and technologies in the health sector in countries. So this is something really that has been gaining some momentum. And the way the framework is being implemented is described in what we call the HIS Geo-enabling Toolkit, for which I put the link in the chat. So this toolkit does not only describe more in details the different elements of the pyramid that was presented earlier, but also the process behind the geo-enablement, as well as give you tools that allows to go through this process, like the benchmark that you have seen already also earlier quickly in Anu's presentation, but also some the assessment tools, as well as some tables that helps to develop this action plan. You have here some examples of implementations we did a few years ago with Myanmar, Cambodia, and Vietnam. The case in Vietnam is particularly dedicated to malaria, but you have also use case in the examples for malaria in Cambodia that are related to malaria. So this is something you can have a look at even on your phone to have an idea of the process and the kind of product that are being generated through this process. So the process itself, so to reach this benchmark that are presented across the 9 elements of the HIS geo-enabling framework, we follow a simple 6 steps process, which we find in the toolkit and which is listed here, which goes from assessing the current level of geo-enablement to defining the strategy and then the action plan, implementing the action plan, and then assessing the result. And this is a loop. So actually, this is something you are meant to redo on a regular basis. So there's really nothing complicated in the process. And what we would like to propose is to take the interested in MCPs and hopefully other programs, because this is really when the geo-enablement reach its full benefit, is when you have this common geography that start to be used by different programs. So malaria, TB, HIV, the health information, the unit in charge of the health information system, of course. So we would like to take all of these programs through the first 3 steps of the process, so that at the end, the final expected product will be an action plan that will be aiming at filling the gaps that are identified during the assessment. And this is something that could then be used to apply for funds, right, to complete the geo-enablement of the LHIS in general or of a specific program like the malaria elimination program. So there is also an example of such a plan in Annex 6 of the toolkit. To give an example of the type of technical supports we are talking about, just recently at the beginning of last month with the support of the Global Fund, technical support has been provided to the 11 French-speaking countries in Africa. So we went through a process where we had a pre-workshop survey to evaluate the current level of enablement, a workshop in Senegal during a week, during which we have not only gone through all the concept and process, but also refined the assessment. And actually what's interesting is we get a very similar picture than what Anu was presenting earlier of what we did back in 2017. So the similar kind of observation in terms of use of GIS software, creation of some thematic maps, but really big gaps when it comes to the institutional framework or all the elements that are there to ensure the quality and the sustainability of the data and also the use case using geospatial data and technologies. And then after the workshop, so this is what we have been doing now for a month and we'll continue until the end of the year. We have one-on-one interaction with 10 of these 11 countries, helping them to develop their own action plan, which they could be presenting afterwards to donors. So what we would like to be doing is something similar for APMEN member countries, in the sense that it's also a 3-step process. It's just organized a little bit differently. The first step is just for you as an MCPs to express your interest today of being part of this exercise. So to basically go through the assessment of the current level of the geo-enablement of the health information system in your country, and also to develop an action plan after that to fill the gaps. So that should not take you more than 1 minute. And the second step will be then to complete the HIS geo-enablement survey as an MCP, but also invite other programs to do the same before the end of January. So this is something that takes a little bit longer, but that should also go easily and not more than 1 hour. And then as a third step, we're looking at organizing and then for you to attend an HIS geo-enabling workshop to take place during the first or the second quarter of 2024. So a week of workshop, a little bit similar to what has been done in Senegal, during which we will work together at refining the result of the assessment and helping those participating to basically develop this action plan I was mentioned earlier. So those who are willing to join in, you have here the QR code and the link. I think it's going to be put also in the chat. So I will invite you to fill that form before the end of today, and hoping to have you on board very soon. Thank you.
Thank you, Steve. And we'll also put the links out in the monthly newsletter as well. So there'll be other opportunities for the wider group. So we're going to go back to Sazid. Sazid, how's your sound?
Can you hear me?
Yes, great.
Okay. So, sorry, again, problem with the screen.
Sazid, I can also share the slide and you can present if you would like, I think.
Yeah, Sazid's chatting, he's telling me he's got internet problems.
If it's moving?
Yes, it is, but I can also share if that would be more helpful for you.
No, it's okay. I think if it is okay for you, so I can continue.
Okay, great.
So good afternoon, everybody. I'm Sajid Ibn Zaman, Group Mappers Lead and GIS Specialist at Moro Epidemiology. I'll talk about Moro geo-enabled microplanning, a data-driven approach to malaria elimination in Bangladesh. So I will start by looking at our current malaria situation in Bangladesh. Left map highlighting the malaria endemic sub-districts that illustrate in 2023, the total number of malaria cases for the entire country was more than 15,000. On the other hand, right map refers Bandarban district, which is a hotspot for malaria in our country. A significant 9,294 cases were recorded until November in Bandarban. Moreover, 91% of malaria cases are found in Bandarban, Khagrachari, and Rangamati, where Bandarban accounting 76% of total cases. And this concentration highlights the significance of focus initiatives in this area, in line with the objective of achieving zero transmission by 2030, as outlined in the National Strategic Plan. My presentation centers on our position within the WHO UNICEF Geo-Enable Microplanning Framework for malaria elimination in Bangladesh. The National Strategic Plan underscores the need for case stratification at a granular level, a process essential for reinforcing the elimination strategy, and we have made the significant strides in stage 2 and 3. Our strong commitment to following guidelines is in preparing code data supported by MORU's invaluable guidance, and funding from ITPA and APMEN has enabled us to do the crucial groundwork. We have successfully developed 80% of geo-enable data for Bandarban, the country's most endemic district. Looking ahead, we are confident to assist the National Malaria Elimination Program starting in 2024, primarily focusing on Lama, a sub-district of Bandarban, as we have geo-enable data for the last 1 year. In 2021, we initiated village mapping in the Lama sub-district, establishing the system with funding from ITPA. In 2022, supported by APMEN, we updated the village list and conducted training session for more than 400 health workers on malaria data collection. Presently, with backing from MORU, we are actively collaborating with National Malaria Elimination Program to expand the mapping initiative, including health facility mapping across the entire Bandarban district. The national guideline and recommendation serves as our guideline principles. By 2030, the country's aim is to interrupt local malaria transmission entirely and eliminate indigenous malaria in a phased manner. By 2027, the goal is to achieve zero mortality due to indigenous malaria and maintain this status. One of the key recommendations from 5th Joint Monitoring Mission is the implementation of a village mapping initiative, which enable us to precisely target intervention coverage down to the village level. Geospatial data specification standards and protocol were defined and implemented to ensure availability and quality during our work in Bandarban. Group mappers and health geolab operating under the MORU offer technical support and employ various geospatial tools to ensure the collection of data for geo-enabling microplanning in control programs. In just 18 days, we deployed a team of 12 people to map 6 upazilas, resulting in more than 577,000 building footprints. Among them, more than 312,000 footprints were adjusted, and we created 6,232 grids to ensure comprehensive coverage. This massive amount of data gives us a successful foundation to work with. Following this, we sent the team to the field to collect geolocation of villages. This whole process typically takes 7 to 10 days per sub-districts. We created 28 maps covering 5 upazilas, including 2,073 paras and mohallas and 82 farms and camps. In just 40 days, we deployed a team of 4 people to map these 5 upazilas, and we believe this information can be instrumental in providing interventions to these communities, contributing to our efforts to achieve the last mile of malaria elimination. We have collected operational list of the health facility for 4 sub-districts and employee list for 5 sub-districts, and mapped all the health facilities except pharmacies for those areas. In January, we updated village maps and trained more than 300 health workers in Lama to send real-time malaria data at the village level. For this, thanks to APMEN support, we encountered challenges during health worker training and with the current data collection platform, such as language barrier, limitation on form submissions, and data dependency. We also identified issues with delayed reporting, prompting us to enhance our approach. To address these challenges, we have initiated training session for several health workers, primarily supervisors of grassroots level workers. This training follows TOT format, and we are currently implementing and also closely monitoring the training conducted by supervisors to the subordinate. Fine scale malaria risk based on API can be generated using the data we are collecting. The malaria hotspot maps can be created by conducting a cluster analysis based on the API level maps. This analysis takes not only the number of cases into account, but also the proximity between villages. We can generate map of travel time to reach nearest health facilities from each village. For this analysis, we need additional set of data apart from the admin units and health facility information, location information. For example, transportation network, hydrographic network, land cover, digital elevation model, village location, population, and also the travel scenarios. So this table shows the findings from Lama sub-district and most endemic union Rupushipara in Lama, which we have got from the dashboard that we developed. We find 295 infected villages out of 644 in Lama sub-district and 60 villages in Rupushipara Union. The program can investigate the case with treatment after 1 and 7 days. The majority of cases in both regions are more people, suggest a possible concentration of the cases which specific communities. While there are variation in the most affected age group between the two regions, it is clear that individuals engaged in agriculture-based occupation in both areas are more susceptible to malaria. 3.6% of people did not use LLI in the last 15 days. Therefore, other preventive measures should be considered for the specific occupation and age group. The data reveal distinctive patterns in the malaria transmission between Lama sub-district and Rupushipara Union. Lama exhibits its highest peak in July, hinting at an upsurge in PV cases during the monsoon season, whereas Rupushipara witnessed its peak in April, signifying a prevalence of PF cases during the pre-monsoon season. So not only at the union level, but we can also narrow down to the smallest unit to identify cases. Headman Para in Rupushipara Union stands out as a hotspot with the highest API and concerning infection rate, 42 cases out of 70 individual. These detailed data highlighting specific areas in need facilitates, promotes attention and target resource allocation. And this is my, I think, last slide. So thank you all whoever support in behind our success. We are very grateful to them and hope for their continued support. Thank you very much.
All right, thank you, Sazid. So we're going to take 5 minutes of questions. We've got 3 in the Q&A. If the speakers could put their cameras on, that'd be great. I think Dr. Siv has had to dash off. He's just been called away. And I noticed Peng B, who works with Dr. Siv, is on the call. Peng B, would you be willing to take any questions? Or are you not able to talk?
Yeah, I will write a question to the chat.
Okay. So our first question, and also the third question, are both about geolocating mosquito species, mosquito breeding sites. So it was a question about, is it possible for entomological surveillance to GIS locate mosquito species and breeding sites? So Peng B is well placed to answer that. Maybe Sazid also.
So I can give an answer from my side. Actually, in Bangladesh, I didn't work with the mosquito data for the malaria disease, but I worked with the dengue, so where we collected the Aedes mosquito breeding space. There is the program conducted 3 consecutive, I think, survey in pre-monsoon, monsoon, and post-monsoon survey. So during that time, they collected the I think Aedes mosquito larva pupa from different house and from different structures. So during that time, we provide them the technical support to cover to make the appropriate coverage. So we identify some certain of places where the surveyor move and they collect they consider that area not going move to the other area. So this I think during that time actually as they follow the map with their device, so they can look at their places, not other places, and they can fill up the cover. I think make it the representative. So I think this is definitely possible to collect the vector mapping as well.
Yeah.
From my experience.
Great, thank you. There's a question from Prudence about data protection issues. She mentions population movement as a particularly sensitive type of data and potential security issues in conflict situations. I wonder if Alukma, you'd like to take that question.
Sure, I can take it. A really good question, something we deal with on a regular basis. But I'm guessing, of course, you mean collecting data using remote sensing equipment, since we can't take informed consent like we can in primary data collection. I mean, I think for this, we have to be very careful in how we are collecting data and make sure that make sure that there are data protection measures in place and protocols in place and ethical considerations in place. I mean, all organizations who are, at least the bigger ones, would have an ethics committee. So you have to explain how data is collected, whether that's done for satellite data or remote sensing, data captured from remote sensing equipment. It's not, unfortunately. I don't have a solution for that, but I think you just have to have measures in place that we can protect the right, individuals' privacy rights and just make sure that the data is ethically used. I'll also invite Steve to talk about it because I'm sure he's dealt with it a lot of times in his career. Thanks.
Thanks. Well, it always depends the level of disaggregation at which you are basically collecting your data, right? And what kind of data you are linking to a specific geographic location. So this is something which you need to think about from the moment you look at defining your, what I will call data ecosystem, and at which level of disaggregation you need the information to be able to support your program, especially when it comes to micro planning. And therefore, indeed, depending on the level, you end up with start, like Anu was saying, to kind of involve the ethical committee as soon as possible to make sure that you have not any problem on the long term. Over.
Great, thank you, Steve. So we are on time, and that's the end of the session. I'd just like to thank all of the speakers. I think that was a really good discussion, and just a reminder that there was a link in the chat which we're going to put again for expression of interest for more support and discussion around geo-enabled microplanning. There we go. Okay. So we're reaching the end of the meeting. I'm going to finish just with a brief recap and a bit about next steps, and then we'll have a poll for feedback at the end. So another 15 minutes around about before we finish. So we've had 4 main sessions. We've covered data-informed interventions, had a panel discussion on data sharing, cross-country collaborations for surveillance and response to border malaria. We've had presentations and a discussion on sustaining malaria services, particularly focused on community health workers and health access in diverse settings. And then we've just heard about geo-enabling of malaria interventions. We've had breakouts, plenary discussions, and lots of Slido, thanks Marina, on lots of things that we were planning to do in the coming year. So thank you for the feedback and also for the suggestions for what we should be focusing on. We had a session on training, so we are planning training in the next half year. So the votes for in-person training in particular in Q1 to next year. For data analysis and visualization, the top topic was detecting or early warning for outbreaks. Number 2 was AI-based analysis tools, and then number 3 was mapping cases. To some extent, we should be able to cover all 3 of those topics, but we will focus our efforts as APMEN on the first, and then you've already heard from some of our Chinese colleagues and my co-chair about AI, so they have potential plans to provide some training on that too. We talked about our new special interest group in border malaria, covered the scope of work we offered for people to join, and we've identified next steps for that. We talked about the malaria CHW performance assessment guideline with the outline and then preliminary writing teams. We've asked people to join and discussed a bit about what the next steps will be. And then for geo-enablement of health information systems for our country partners, we covered the process to assess the current status and also potential for support for countries through APMEN. And then we've had a vote on our surveillance response working group activities in general. So our monthly newsletter will continue. We've been asked through the vote to provide more technical content, so we're working on that now. And then we are going to continue doing tech talks, so particularly surveillance response for mobile and migrant populations, case studies of targeted interventions, and also prevention of reintroduction have come up as potential topics for the meeting. Next slide. So next steps, we're integrating all of your suggestions into our 2024 work plan, which we will get agreement from APMEN and APMEN to take forward. Continue the knowledge exchange of the newsletter and tech talks, with at least 2 tech talks. We're also going to be doing the scoping survey, as we discussed, to build this cross-border malaria knowledge repository for the special interest group. And then we'll be hosting, organizing some peer learning exchanges between country pairs, which we've called here C2C. We'll be doing the capacity building, so training on data visualization and analysis, but also looking for APMEN member organizations to help deliver other training. So either that training is already planned, or we'll work with them to produce training on other topics that have come up. And then technical support initiatives, as mentioned, on geo-enablement and action plans for how to do that for different countries. Our next annual meeting will be in person, so we look forward to meeting some of you face to face. It will be during 2024, and the date and location are yet to be determined, but obviously we'll let you know as soon as that's been decided. Please feel free to contact us if you've got suggestions for what you want to see in that meeting. So particular topics or areas for discussion, things that you would be interested to see presented, and people that we should invite to present. Very open to that, and it's early days of the planning for that meeting, so we're open to anything at this stage. So with that, we should have a poll to see how much you liked the meeting, and if you've got any suggestions. Hopefully that's going to pop up on the screen. There we go. So please be as frank as you can, because we use this feedback to plan the next meeting. We won't take it personally.
And I see Professor Joe's on call already, so maybe we'll leave the poll on for about 3 minutes, Richard. What do you think? And then we can ask Professor Joe to just deliver the final remarks for the meeting.
Great suggestion, yeah. So yeah, it's working. We'll leave it up. We'll wait for at least 20 people to fill in the poll, and then we can move back to our chair, Professor Joe, for his closing remarks. So we're at 1 at the moment. It's just 4 questions. So are there any problems with the poll? Because it's looking like
I was gonna say
Okay.
phone. I think it's not showing for some people. Phone, is it all right to replay it? I don't know how it would work. To redo the poll, we're just getting a lot of comments from
quickly
people.
relaunch it. Let's have another go.
Okay, second time. Thanks to everyone who let me know.
First
in the
person is
chat.
right then, but let's see. Okay, it's working. Great. Let's see if we can get to 20.
While we wait for this, I actually see one question in the chat that's addressed to UNICEF about the DHIS2 use. If Anu or anyone is able to respond, maybe they can type a quick response to that. Maybe the curious participant.
I know had to leave because it's like 2 o'clock in the morning.
Oh, pardon.
But
Yes.
I'll pass the question to her. We'll maybe get an answer back.
Yeah, thank you, Steve.
Thank you, Steve.
Okay, we're at 20. Should we leave that up and then move to Professor Shore?
I think if you leave it up, it kind of blocks the screen for those who are signing in from their phones.
Oh, okay. Okay.
So I think maybe
We'll have to end it.
yeah, we can end it. I think it's okay where we're at.
Right.
Right, Phone, maybe you can end the poll and I will invite Professor Cho to just quickly deliver some closing remarks for the meeting.
Yes, can you hear me now?
We can hear you, Professor Cho.
Okay, thank you, ladies and gentlemen, esteemed colleagues and distinguished guests. And it is my honor to conclude this meeting. And first of all, I'm deeply honored to stand before you as the co-chair of the APMEN Surveillance and Response Working Group, sharing this esteemed role with Professor Richard Mood. Together, we extend our thanks to all of your efforts contributed to this year's APMEN Surveillance and Response Working Group annual meeting for 3 days. And this year's theme, catalyzing innovation, cross-border synergies, and sustainable impact, advancing malaria elimination through surveillance and response in the Asian Pacific. So encapsulates our collective commitment to pioneer solution and foresting cooperation across the borders. Through this meeting, we achieved our objectives, that is to explore data-driven approach, facilitate cross-border partnerships, and ensure the sustainable impact of malaria elimination efforts across the Asian Pacific region. At the same time, allow me to share my great pleasure in announcing my role as a co-chair for 2023 to 2024, joining Professor Richard Mood, who has adapted the working group for the past 3 years already, with Mahado Oxford Tropical Medicine Research Unit, or MORU, as the host institution. With this change, I'm excited to bring these experiences behind China's CDC to enhance and continue to deliver the activities that are the priority for malaria elimination through the working group. Secondly, as I conclude this year's APMEN Surveillance Response Working Group annual meeting, it is essential to acknowledge the wealth of knowledge we have gained through these enriched sessions during the last 3 days that unfolded during these 3 days. And over the past 3 days, we have immersed ourselves in the theme of catalyzing innovation, cross-border synergies, and sustainable impact. So on the opening day, we still remember we explored how to optimize our surveillance data for precise targeting of malaria interventions. Our journey spanned from the genomic surveillance advancement to the integration of artificial intelligence or AI, illuminating the pathway for more effective control on malaria and prevention. During the panel discussion on the broad malaria key data sharing priorities, we outlined emphasizing immediate outbreak information sharing and the importance of local level data for effective cross-border cooperation. Challenges in certain data sharing were acknowledged, particularly concerning population movement, while a call was made for the international support to fund routine cross-border meetings and projects facilitating ongoing cooperation. Today, our focus shifts towards completing the sustainability of our efforts. The panel discussion brought forth perspectives from various stakeholders to drive the discussion on sustaining community health workers, a key component of the malaria elimination strategy in our region. And in our final session, we also explored how the geo-enabling process of our malaria information system strengthens the health information system as a whole to ensure that our investments contribute to the sustainability beyond the malaria gains. Thirdly, we made and improved our working plan for the APMEN SRWG. Through this meeting, our breakout and plenary discussion developed deep into the critical areas, shaping the foundation for the SRWG's future endeavors. Together, we prioritize training topics and define the actionable plans for the special interest groups, or SIG, on the board malaria, and form the dedicated writing teams to ensuring the pathway for developing a malaria community health worker assessment guidance. We also share the plan to assess and support countries in geo-enabling their health information systems and activities that we commence from now until January 2024. Embracing a cooperative spirit, our votes on the APMEN SRWG activities has charted the path for our ongoing activities. Expected to continuing seeing our monthly newsletter with the special quarterly issues, brimming with more technical contents, and the tech talks exploring key topics that you have helped identify. Furthermore, your endorsement of country 2D support underscore our shared commitment to further strengthen peer learning exchange between APMEN countries. Last but not least, I want to express my sincere appreciation to each of you and for your unwavering dedication to the malaria elimination efforts in our region. Your active participation, engaging discussion, and forging of new cooperation have undoubtedly been the driving force behind the success of this gathering. I extend a heartfelt gratitude to our esteemed speakers, panelists, and the contributors who have enriched our discussion with their insights and expertise. Your contributions have been instrumental in shaping the SRWG and our collective pursuits of innovative solutions to sustainably elimination malaria in this region. As we can close this chapter of the APMEN SRWG annual meeting, I encourage you to carry forward the momentum generated during these 3 days. Let the connections made, ideas exchanged, and the lessons learned serve as catalysts for continued innovation, cross-border synergies, and sustainable impact in the ongoing fight against malaria in the Asian Pacific. As said by Professor Richard Mote, we will see each other next year, then probably in the middle of next year in Shanghai, I hope. Once again, thank you all of you to dedicate this meeting, and I look forward to enrich the conversation in the future. Thank you so much.